Hi, everyone. My name is Mahadno, and I'm the staff governor. We're here today to talk about specialist palliative care within our trust, looking at pre, during, and post-COVID pandemic. There have been recent developments in palliative care in light of COVID pandemic, and how palliative care aims to become a more integrated service across the whole of the trust. To talk to us about that today is Dr. Ben Clark. Dr. Ben Clark, he has been a consultant in palliative medicine for 10 years and has worked in the East of England and Imperial College Healthcare Trust in London before joining CUH in November 2020. Before entering palliative care, Dr. Clark worked as a psychiatrist, and although he has never regretted changing specialties, he retains an interest in areas where mental health care and palliative care overlap. Academically, Dr. Clark's research interests are around human factors, motivation and performance in healthcare teams, and his MSc thesis on motivators for GPs having end-of-life conversations with patients was awarded the prize for best postgraduate dissertation at Birkbeck College. Alongside Dr. Clark's clinical work, he has been a foundation training program director for first and second year doctors at Charing Cross Hospital. And he currently holds the role for patient safety lead for Division C with the CUH. And it's his view that safe practice and kind practice to go hand in hand. Dr. Clark took over as a specialty lead for the palliative care department on the 1st of April 2021. Dr. Clark, welcome.
Thank you very much. I hope I have unmuted myself, and I hope I've successfully managed to share my slides without accidentally revealing something else on my desktop. Thank you, Namu, for the thumbs up there, and thank you to everyone for joining this evening and listening to what I hope will be at least an informative helicopter view of where specialist palliative care at Cambridge University Hospitals Trust is. I will go through, I hope in a timely fashion, what we mean by palliative care and how that relates to end-of-life care, and then move on to talking about how palliative care works in hospital settings and touch on what we mean by the priorities in care of the dying. I will then talk a little bit about the palliative care department at CUH itself, how it started, how it's developed, and including the roles of the breathlessness intervention service, psychology, our enhanced supportive care clinics now moving to 7-day working. I will describe my understanding of how COVID really impacted on our team and summarise where we're at the moment, and then finish by talking about where I think palliative care at this trust needs to develop to meet the needs of the future. I would like to dedicate this talk to Dr. Sarah Booth, who we sadly lost earlier on this year. Sarah Booth was the first palliative medicine consultant within this trust and really laid not just the foundations, but pretty much all of the blocks of palliative care as a department and a service and team upon which and within which we're all working today. I never had the pleasure of working with Sarah, but I did have the privilege of meeting her a few times, and she is sorely missed. So when I talk about palliative care, I find that there are two camps of people. There are people who really do understand palliative care, and then there are those who really haven't come across palliative care at all. So on the occasions that my social life allows it, and I go and meet people at parties and I explain what I do, it is not uncommon for me to need to explain what it is that I do. I'm starting here because some of the questions that came to Namu when we advertised this talk were very much about what was palliative care. And so my apologies in advance to those of you in the audience who already know and understand this. I will be, for a lot of you, saying what you already know, but for those who do not, I thought that this was probably the most helpful place to start. For those of you who are tuning in who really don't know very much about palliative care, as a disclaimer, I should say that a big part of what we deal with in palliative care is looking after people who are sick, who are dying, who are very near the end of life and go on to die. Our goal in palliative care, in part, is to make that process as comfortable, as peaceful, as dignified, and as positive, if that doesn't sound counterintuitive, as possible for everyone. When I teach medical students about palliative care, I always like to start with some etymology. It's always a safe place to start by thinking about what the meaning of words are and where we start. And the word palliative really comes from a Latin or French word meaning to cloak or to cover. And in a sense that we place a warming, soothing blanket over something that underneath might not be pleasant. I could expand on that, and many people better, smarter, and more articulate than I am have written down definitions of what palliative care is and what it means. The one that I often refer back to when I'm talking to people about what it is that I do is that palliative care is an active, holistic approach to people with advanced, progressive, what some people might call terminal, what other people might call life-limiting illness. The way I paraphrase it to my patients on the ward is, particularly in hospital, is I will explain our role works alongside their treating teams. And while the clever doctors, surgeons, nurses, therapists, while their job is to get people as well as possible, our job in palliative care is to make sure that people are feeling as good as possible. And feeling as good as possible is a combination of feeling physically comfortable, free of pain, not short of breath, not sick, not vomiting, as well as making sure that their emotional needs are met, that they're feeling emotionally and psychologically as good as possible, that their family is supported, and that their spiritual needs, not just faith and religion, but their spiritual needs overall are equally met. Because our goal is to make sure that people are feeling not just as good as possible for as long as possible, but that they have the best quality of life that they can. And although sometimes that is associated with death and dying and people being in the last hours and days of life, a lot of what we do, a lot of our approach to care is just as relevant at earlier stages in someone's illness, and sometimes earlier than people might otherwise think. I said earlier on that when I meet people at parties, when I'm talking about palliative care, some people I meet do have already some preconceived ideas of what palliative care is and what it means. Some people associate palliative care with the image on the left of people who are very unwell, very sleepy, possibly even rather drugged up on some of the medicines that we use to alleviate pain or distress. For those people who are interested, I can commend A Death of Ivan Illich as a very good and easy read short story that really captures some of what we do in palliative care and what people at the end of the life might go through. But there are other people who've had experience of palliative care that have been much more modern and much more positive, and that really is the image of the gentleman on the right, where actually, although they have a life-limiting condition, their quality of life is enhanced by the holistic care and support that they get, partly through the contribution of palliative care. But palliative care isn't without its taboos either, and actually in a hospital setting, those taboos can sometimes still be very relevant. I said that we are commonly associated with death and dying because of the nature of the patients that we look after, that we care for. And there are some people who, for understandable reasons from what they have been told, what they have heard, perhaps what they have seen, associate palliative care with imminent death. There are other people who sometimes associate us as being the harbingers of death, and that us bringing a palliative care team in means that somehow a person's death is going to be hastened. To anyone who's watching this who does have that view, I can assure all of you, getting palliative care involved, even for patients who are unwell, for whom their recovery might be uncertain, palliative care does not diminish patients' chances of recovering at all. And in the right places and in the right settings, sometimes it even improves people's chances of getting better. There are other characters that sometimes I associate working with palliative care, working in palliative care feels like. There are some on the call who will know what I mean when I refer to us as being a Cinderella specialty. We are the epitome of the Cinderella specialty. For those of you who have not come across that term in brief, palliative care is not a particularly sexy nor a particularly technical specialty. We are always the last to be invited to the party. We don't get very much money, a bit like cinders. And anthropologists in Australia have commented that palliative care exists on the conscience of society. There's another character that I find myself identifying with more often than not, and that is the character on the right. And for those of you who are not as engrossed by classical mythology as I might be, if I say that the lady on the right is Cassandra of Troy. Cassandra was the eldest daughter of King Priam of Troy, sister to Paris, he who kidnapped Helen and kicked off the Trojan Wars. Cassandra was blessed with the gift of prophecy and cursed never to be believed. And I will come back to why I sometimes feel like Cassandra in a little bit. Palliative care isn't a new thing. And if we're realistic and honest with ourselves, a lot of what medicine and healthcare was before the 19th century was all about related to symptom control and care of the dying. And indeed, even in the late 19th, early 20th century, a lot of medicine and healthcare was about trying to alleviate suffering. When I think about and look at the history of palliative care, a lot of the movers and shakers in palliative care, strangely, were surgeons. People like Norman Barrett were early proponents of giving oral morphine to the dying. But alongside that, other approaches, other things that we do in palliative care were being developed by other disciplines like geriatric medicine. So Marjorie Warren, who was a huge champion of multidisciplinary care for whole patients, we took and we borrowed that concept in palliative care, but we can't really pretend to have invented it. The big grandmother of modern day palliative care was Dame Cicely Saunders, sadly no longer with us. Cicely started out life as a social worker and then trained as a nurse and then trained as a doctor. And she was moved by the plight of one of her lung cancer clients in the 60s who bequeathed her a small sum of money to insert the window in her first hospice. And that hospice was St Christopher's down in Sydenham that opened up in 1967. It took another 10 years for there to be the first hospital-based palliative care team, and that was at St Thomas's Hospital in London. And it took another 10 years after that for palliative medicine to be recognised as a medical specialty in the United Kingdom, and another 10 years after that for us to get our first Oxford textbook, which is now running into its 5th or 6th edition. Palliative and end-of-life care didn't really hit the national stage in consciousness, though, until the noughties, with the publications of 2 documents, the NICE Guidance on Supportive and Palliative Care for Patients with Cancer in 2004, and a National End-of-Life Care Strategy in 2008. And within that is a quote that I refer back to, that is, how we care for dying people is an indicator of how we care for all sick and vulnerable people. And it's also a measure for society as a whole and a litmus test for health and social care services. So this is where we were at in 2008. And we thought of end-of-life care as not just being about the last days and weeks of life, but we thought of end-of-life care as being the last year of life. But for people, particularly in a hospital setting, an innovation from Liverpool, you adapt and integrate an integrated care pathway in order to help introduce hospice standards of care for dying people in a deliverable in a hospital setting was rolled out, and that was the Liverpool Care Pathway. And I said before that sometimes palliative care and end-of-life care carries with it a taboo. And the Liverpool Care Pathway, in some senses, unfortunately, fell foul of that perception. That perhaps was not helped by other interventions, but a document, a piece of work that was designed to improve the quality of care and alleviate the suffering of people in the last days and hours of life became, in my view, misinterpreted as something that was seen to make death and dying happen. And that then led to a lot of soul searching on the national stage and a very in-depth review led by Baroness Neuberger in 2013 entitled More Care, Less Pathway, that led to the withdrawal, not just of the Liverpool care pathway, but in lots of ways the term pathway when it comes to palliative and end-of-life care. And I'm at pains to point out to people within who talk about people being on an end-of-life pathway that we have really tried hard to move away from that kind of terminology. We went on to have a review published by the Leadership Alliance for Care of Dying People entitled One Chance to Get It Right, because when we're looking after people at the end of their life, we really only do get one chance to get it right. And they talked about 5 priorities of care of dying people. And those priorities are not revolutionary. In many respects, they are the same priorities that are relevant for managing and treating any kind of healthcare problem. Because if we are going to treat a problem properly, first we need to recognise and diagnose it. If we're going to do that properly with our patients at the centre, what we do, we need to be able to talk to them about it. It's good practice to involve people, particularly families, around that patient, and we need to be supporting them. And finally, whatever action plan we come up with, we then need to put it into action. In a hospital setting, for me, I would say that it's that first priority that is critical. If we've recognised that someone is dying, if we have been able to diagnose that process, everything else that we need to do follows, often quite logically and straightforwardly. Not always, but most of the time. And I said before that sometimes my life can feel a little bit like a Cassandra syndrome. Recognising dying is not easy. It is practically and intellectually not easy. It is emotionally difficult. It is emotionally hard to accept sometimes for patients, for their families, for their treating teams. But if we are going to get the care right, that is the first thing that we need to be able to do. And at this stage, I'm just going to take a step back and touch on a little bit where palliative care and end-of-life care are slightly separate. They're overlapping concepts, that is certainly true. And while some of specialist palliative care is end-of-life care and some of end-of-life care is palliative care, the two are distinct. As palliative care physicians and teams, we can be involved in patients even with life-threatening and potentially treatable illnesses. And there is a lot of end-of-life care that does not necessarily need a specialist palliative care to be involved. We say within palliative care that end of life is everyone's business, and any nurse, doctor, allied healthcare professional should feel comfortable with meeting the needs of their patients who are nearing the end of their life, but also know when to call us as the specialists if there are things that are complicated or difficult. And we do know, we have known for some time what matters to people at the end of their life. I always like this paper because it gives a good top 10 of what matters most to people. Coming in at number 10 is to maintain their sense of humour. In a hospital setting, that's really important because a lot of people actually get quite bored of being talked to about their illness, what's happening. And if my patients can laugh at my jokes, that gives you a good threshold about what people's level of need for entertainment is. Number 9 is to be free of pain, which surprises some people. We've got another 8 to go, but being comfortable comes in kind of lower down the list of the top 10. Having their financial orders, their financial affairs in order comes higher than that, and being able to trust their doctors, which makes sense. Maintaining their dignity, which is a really big focus for us for looking after people nearing the end of their life, and having someone who will listen. Knowing what to expect, knowing what's coming, that's at number 4, and having a nurse with whom they feel comfortable is number 3. Number 2 is having a named decision maker, knowing who is actually making decisions for them. But number 1, and this is the one that I always emphasize to be kept clean. Nothing complicated, nothing surprising, nothing difficult, but just to be clean and dignified. That is the number one that matters to our patients. And when you look at that list, when you think about what the difference is between specialist palliative care and end-of-life care and generalist palliative care, I would suggest to you that there are only really 2 of those top 10 that might need a specialist to come in. The vast majority of palliative care is delivered not by us in specialist palliative care, but by the generalists, by dedicated nurses, doctors and therapists on the wards and out in the community by GPs and district nurses who don't need palliative care to help because they know what they're doing and they care enough about their patients to get it right. One thing I will say though is that when we think about palliative care, when we think about the role of palliative care in a hospital setting, people who come into hospital don't come into hospital with a label of I am dying or I'm nearing the end of my life. People come into hospital with a label of I am sick, and the implication of being sick is, as doctors and nurses, we're going to treat them and make them better. And there used to be a perception that palliative care was really only the thing that started after active treatment, curative care had finished. These days, we think about palliative care and active treatment as being more overlapping, and anyone who works in the trust, anyone who's read my notes will see in big bold at the top of pretty much every entry that I write, palliative care and active treatment are not mutually exclusive. And as someone moves through their disease journey, at the beginning, they might just need a little bit of palliative care to help with symptom control, to help with pain, to perhaps help with some psychological support. But then we might dip out and we might not need to be involved again until much later on in someone's journey. And as someone moves through that journey, their relative need for life-prolonging disease-modified treatment might get less. Their need for palliative care might get a bit more. And the other thing I would say is that good palliative care carries on with families beyond the point of death, and good bereavement care doesn't start at the point when someone dies. Good bereavement care starts by those honest, open conversations with family members, with loved ones, to detoxify those things that people worry about, death and dying, because the things that people worry about happening if someone is nearing the end of their life are generally much worse than what actually happens. And so to illustrate the point, I just want to share with you 2 patient stories very quickly at both ends of that spectrum. The first is a story of a 41-year-old man that we helped look after over the summer. He was very keen that we share his story with as many people as possible, so that he could contribute to learning and practice. He was 41, is 41, has had a previous organ transplant and came down with monkeypox over the summer. He had horrendous mucositis. He couldn't talk, he couldn't swallow. Nothing was working. He tried, opioids had been tried, but what could be given was limited because of poor renal function. Patient-controlled analgesia pumps had also been considered, but in desperation, he was referred to us in palliative care. And we had to think about this because this wasn't something that we'd seen before. And after a bit of a conference between some of the specialists, we decided to give 2 pretty specialist medicines, something called alfentanil, which is a relative of morphine, but much more safe in renal failure, and ketamine, which is, for those of you of veterinary knowledge, you'll associate it as being a horse tranquilizer, but in palliative care, we use it a lot for difficult neuropathic pain. It's very good for ischemic limb pain. It can be very good for burn pain. And so we started him on both of those, and his pain got a lot better. And within a week or 2, his pain was so good that we were able to take down the ketamine and wean off the alfentanil. And he was discharged home a much happier man. So a man with a really difficult illness, with really challenging symptoms that we could help. And he continues to be seen in his renal transplant follow-up to this day. At the other end of the extreme is Michael. Michael was a 70-year-old man, previously active, loved outdoors, loved bird watching. He had a background of lung disease, but he came into hospital and was in hospital for quite a long time with recurrent pneumonias and inhaling food and fluid. He underwent several courses of antibiotics, and he was desperate to be discharged home. And he was really referred to us for a request for help with conversations and with a buzz phrase, I hear now and then, he's not palliative. He'd been in hospital for 66 days when we met him and on his 6th course of antibiotics, and communication did need help because he had hearing impairment and he had slightly inconsistent wishes. He would want to be treated, but also was quite keen to be out of hospital. His overriding wish was to be discharged somewhere with a garden, to be close to nature. And we were involved for about a month, during which time he underwent quite a lot of active interventions, including more antibiotics and a lot of changing of wards as well. And the two things that the palliative care team provided were continuity and to keep the teams who inherited him updated on what had happened before. And it got to the week before Christmas and things were still going in circles. And I went to see Michael on another ward and spoke to him about what he wanted. And I spoke to his team about what had happened, because I think he was on his 8th or 9th cycle of antibiotics at that point. And he would respond, go for a week or two, and then get another infection and need some more antibiotics. And it was getting to Christmas Eve, and I sat down with Michael and said, actually, how long do we carry on doing this? And at that point, Michael was very keen to just be out of hospital. And we thought that was the nicest Christmas present that we could give him. And this was his nursing home, and he had a lovely time for the month that he was there. And he did need to be readmitted then after about a month, but because we knew him, we could pick him up on another ward and speak to his doctors on another team and explain the situation and reassure them that Michael's overriding wish was not to be in hospital for a day longer than necessary. And so after a very short readmission, he went home, and a few short days later, he died in his care home, surrounded by his books. We got a phone call from his GP the day afterwards just to check in and let us know. And his GP described his room as being like a library. And his brother wrote a really lovely email back when I asked him permission to share Michael's story with this talk, because his brother was so pleased that we'd been able to make sure that the things that mattered most to Michael, and by extension to him, had happened. And when our patients and their relatives describe us as being the golden thread of continuity, that at least reassures us that some of what we're doing is worthwhile. But there wasn't anything magic about what we did. There wasn't anything specialist about that. We were there and we met the person's needs as they were at the time. But in hospitals, we need to be careful. There is a balance to be struck. And I've said a couple of times now about how important recognising dying is. That's also true in another way of being accurate in diagnosing dying. Because when we don't accurately recognise dying, when we misdiagnose dying, then we make errors. And sometimes those errors reach catastrophic proportions. So I'm constantly mindful that within hospital, although we have lots of people who are in the last days or weeks of months of their life, we can only start managing people as though they are dying when we are sure that that is the case. And if there is uncertainty, then we need to acknowledge that too. Because the honest truth is that when it comes to looking after people who are dying, a lot of the principles are very straightforward. We just need to recognise that a lot of the rules have changed. Someone is no longer sick, they're at the end of their life, and therefore less is more. Fewer medicines, fewer burdensome investigations. It's our patient who's in charge, and we need to be listening to them. And communication is key, and we mustn't forget their families. And that brings me on to the palliative care team at CUH. There has been a palliative care team at Addenbrooke's Hospital for over 30 years now. Sarah Booth, who I mentioned at the start, joined the team in the mid-90s. And for those who worked with Sarah, they credit her with being the trailblazer in building the trust and the relationships and the team size and the resources within the palliative care team. The office I'm sitting in, we only have because of Sarah doing a safari of the hospital and finding this office space. She was absolutely innovative, and it was her work on breathlessness that led to the creation of the Breathless Intervention Service, which is now internationally recognised as a world leader in supporting patients suffering with dyspnea. Sarah handed over the reins to one or two successors over the course of the noughties and the 2010s. And it was my immediate predecessor, Dr. Rosemary Wade, who really drove the creation of a new form of specialist support nurse to help not just provide specialist palliative care, but also to empower the wards and provide point of care teaching for those clinical areas where patients were needing more generalist palliative care. And our role, our work, our team continued to enhance and develop. In 2018, we started to do 6-day working, and that we also at the same time started to run enhanced supportive care clinics for cancer patients. So that is palliative care clinics for patients who are still undergoing cancer treatment for incurable cancer, but for people who still have a prognosis of months and years, to give more timely and earlier input of palliative care approaches to complement their oncological treatment. And then in 2019, our team was sufficiently staffed to be able to provide a 7-day face-to-face service across the whole hospital. And we also, through Rosemary and others' hard work, formed a relationship with the Arthur Rank Hospice in order to have nurse-led hospice beds for people in the last days to short weeks of life. And then COVID happened. And this is sort of where I come in. I joined the trust in November 2019. And no, it would be 2020, I'm sorry. And COVID had already been underway. I was in London at the start. And I think the experiences in London and Cambridge were a little bit different. But COVID was a very strange time for all of us. It was a scary time. It was a worrying time. There was enforced separation from us, from our patients, from families, from their patients, from our teams, from each other. It was an illness quite unlike anything that any of us had seen. People, both young and old, were dying. Some people were dying in very, very sick situations. And from a palliative care team, we saw that impact from our patients to us in a depletion of the number of people that we referred to begin with, as less people were in hospital, as fewer people referred to us. And then as things started to recover, we started to get a few more referrals, but it wasn't very long before the second wave of COVID hit, and again, that really depleted the people who were being referred to us again. And then in that second wave, we started to see more of a fluctuation in a way that I remember from being in London, where as more and more people were recognised as dying and not going to recover from COVID or other reasons, we would be referred those people. But a lot of the time, because we still weren't on the wards as much as we wanted, it could be a quite empty experience sometimes. We would have patients on our list and we would barely have a chance to get to know them before they passed away and died. Alongside that, a lot of our team were called back to the wards. And while certainly those wards that had the benefit of the experience for some of our band 6 and band 7 nurses who were able to go and give some of that frontline work, for our own team, we did feel shorthanded and depleted for a time. And it was a joyous moment when some of our colleagues were able to come back and rejoin the team. We did learn a lot. We learned a lot about how to communicate with patients and families in difficult situations. We learned a lot about liaising with other teams. We developed new ways of working to manage some of those pressures. All of us, not just in the palliative care team, but the world over, got used to Zoom, got used to Microsoft Teams, got used to Starleaf. And some of those ways of working that we adopted within the palliative care team, we still use now to help manage our workload. It was also a big time of change within our palliative care team. I wasn't the only person to come and join. Several of our team left for perfectly valid and good reasons, and we were joined by a fresher, newer cohort of nurses, of doctors, of other therapists over the course of all of that, not just related to COVID, but the two coincided meant that our palliative care team within CUH has undergone a lot of change in the last 2 or 3 years. And we are for it, a younger, fresher, newer team. But as we come out of COVID, we are still resetting. We are still regrowing our team, and we are still redeveloping what it is we do and how we approach things. And part of why we need to do that is because our workload has changed. If we look at the number of people that we're looking at with cancer, for example, historically you would always associate cancer patients as being the mainstay of the palliative care workload. And while those patients account for half of our patient load, there is another half of patients who have non-malignant illnesses, who are frail, who have multiple comorbidities. We have a much older population of patients than we used to. And the reasons why people are referred to us has also changed. We still get a lot of referrals for symptom control. We still get a lot of referrals to support patients in the last days of life. But we also get a good number of referrals for patients who are in their last year of life and need future care planning. And we still get a reasonable number of patients who are referred who are still undergoing active treatment, but for whom palliative care alongside that would be helpful. But that 10% number, my view, might be a little low. I believe, and it is just my personal opinion, that there are many patients on the hospital wards who might also benefit from palliative care involvement, and we are not seeing them at the moment. But I have a fantastic, hardworking, caring, dedicated team of nurses, both clinical nurse specialists and specialist support nurses, of therapists who work in the breathlessness intervention service, of psychologists, of admin team who try very, very hard to keep me organised and to keep me on time. And they're all going to hate me now when they're watching this, because this is them from our away day in April. And I said about resetting and regrowing, and it was really important to us that we had some time to start to redefine our priorities and to move forward. And where we are at the moment as a palliative care team, I would summarise, is we are on a journey as we are coming out of COVID, although we've not completely left COVID behind. When things are difficult and when they are tight, all teams recourse back to being reactive, and that is still in some ways where we are, but we are on a journey to be more proactive, and there are some areas in which we are doing that. As a whole team, we are thinking about our vision, our priorities, our goals, and my view, I suggest, is that one of the things we may need to do in the future is start to become more integrated with those areas, with those clinical areas and clinical teams for whom they are looking after people who are in the last days and weeks and months of life to support. And although at the moment we are being opportunistic in who we meet and who we work with, we will be moving towards being more targeted so we can make sure that we are meeting the needs of those patients who need us most. And we are resetting some relationships in a similar way to our inpatient workload. Our referrals to enhanced supportive care also took a hit during COVID. And one of my consultant colleagues, Yvonne Cartwright, is working very hard with one of our nurse lead, Francis New, to regrow and rebuild our relationships with different cancer specialists. And all of the Band 7 clinical nurse specialists who hold enhanced supportive care clinics work incredibly hard to make sure the patients who are referred to us get as good a care and service from us as possible. We continue to join multidisciplinary team meetings like the Feeding Issues MDT, and we are working with areas like the liver unit, like the kidney unit, like critical care and the vascular surgeons, to start to build some integrated relationships so that that care we give between active treatment and palliative care can be more seamless. And alongside that, we do lots of work within education, and our breathlessness intervention service is the exemplum of a team that delivers consistently internationally renowned education, teaching and training in their study days and in their conferences. We are embracing the work of the Trust in linking with the Institute of Healthcare Improvement, and some of our team are working on a project at the moment to improve the quality of the working day for everyone in the team. And we're also doing some exciting work, and I must pay tribute to Nancy and to our psychologists for all of their hard work in really taking the opportunity to demonstrate and roll out the role of virtual reality for patients who are under our care. And that's a really exciting piece of work that Nancy successfully bid for 2 years more funding so that we could continue that project and roll that out. I need to acknowledge the people we work with in the community at the Arthur Rank Hospice. There is, for those of you who have not come across it, but should you ever need to know about it, a palliative care hub, which is NHS 111 option 3, available for patients in Cambridgeshire and Peterborough. And that was successful enough to be award-winning at the Health Service Journal Awards last year. We also fit in within a national framework, and some of you may be aware of the national ambitions for palliative and end-of-life care. The first set of ambitions were published in 2015, and that was revised and revamped without too much change last year. And the national vision is that each person who is at the end of their life is seen as an individual, that they get fair access to care, that we are working on maximising their comfort and well-being, that their care is coordinated, and that all of us are prepared to care for those people, and that each community is prepared to help. And I talked about thinking about going forwards, and I think it's fair to say that although historically palliative care primarily looked after people with symptoms from a single illness like cancer, and that is going to carry on being a significant chunk of our workload, we are going to be seeing more people like Michael with non-malignant conditions, with multiple pathologies where the prognosis is uncertain, and the common thread through all of that is uncertainty. And we know that those patients are going to be increasing in number, and we know that we are going to be seeing more of those patients in hospitals, and more of those patients are going to need us within specialist palliative care. So this is a journey, and where we are at the moment is building on the achievements that we've already made to develop more. One of the things that I'm constantly mindful of in these mercenary times is that we do need to demonstrate our outcomes and how effective we are. And we are going to need to develop some new posts. I haven't touched on this, but across the country, there's a national shortage of palliative medicine consultants, but also within palliative care, we are the trailblazers for making sure that the hierarchy is flat, and non-doctors are just as capable, responsible, empowered for leading a team in a service. And for a team like ours, I would love nothing more than to see the creation of nurse consultant posts, physiotherapy or occupational therapy consultant posts, other non-medical consultant posts, as well as developing and building on the roles that everyone in the team has. Because what I want, and I hope we can aim for, is a service that's more proactive and more integrated within the inpatients, within enhanced supportive care service, within the breathlessness intervention service, and where palliative care being around is seen as standard and welcome. And alongside that, we need to keep maintaining and developing our teaching programs, our quality improvement portfolios. And if that wasn't enough, it would be a lovely thing for us to rebuild our links with the university. I promise I'm very near the end. For those of you who are interested, there are a few books that I can recommend, but if you would just read one, I would commend With the End in Mind by Kath Mannix, who came to talk to us last year. And Kath writes insightfully, eloquently, persuasively on how important end-of-life care and palliative care is, and how straightforward some of it can be if we know what we're doing. I should conclude with some thanks to my colleagues Simon Eckheim and Yvonne Cartwright for letting me plagiarise their slides and their brains. And a thank you to everyone in our palliative care team and the breathless intervention service team who give their care and their dedication to so many people every day. They are amazing. And thank you to all of you for listening so patiently. And I will stop sharing here and take any questions.
Thank you very much, Dr. Clark, for taking us through that journey of palliative care. We are open for questions at the moment, and feel free to type in questions into the Q&A if you're joining us via Zoom webinar. And if you're joining us via Facebook, leave the questions in the comments and we'll be able to be answered by Dr. Clark. We already have a few questions in. The first one that I'll start with is, in the hospital environments, at what level does palliative care begin to be implemented? Is it first identified by the medical team or nurse carers?
So there are two parts to the answer to that question. If the question is, one is about which professionals, which members of staff are most likely to recognise dying people. And there was some work done by Paddy Stone and Ollie Minton some years ago now that demonstrated, perhaps unsurprisingly if you think about it, the people who are most likely to recognise patients who are nearing the end of life are our healthcare support workers. They are the people who spend the most time with their patients. They are the people who really get to know people and see those changes as they're happening. So on one level, doctors have a role, nurses have a role. It is those people who are there day to day who are most likely to recognise it.
Right.
The second part, though, is about who it is who triggers or initiates palliative care. And I would put that back to saying it is a whole team decision. And I think there are two parts there. Like I said, recognising that there is a need is the first step. Talking to patients about that and their families about that is the second step. And between those two, that is the decision-making unit. There may be some differences of opinion, but differences of opinion are okay. We make our best decisions with debate. The phenomenon that always concerns us, that concerns me, and it's well described in hospitals in the community, is gatekeeping. And that is one of the reasons why I say, as clearly as I do, involving palliative care does not stop people getting better. And if we recognise that someone is going to get better, we can and we do take a step back. But I would encourage anyone who thinks that palliative care is needed and they feel they're being blocked to escalate that. Because at the end of the day, it's our patients' care that matter most.
Thank you for that. Second question that we have is, as a consultant, do you have a team of specialists, or is palliative care part of everybody's training?
So caring for the dying and palliative care is certainly a key part of every doctor's training. Looking after people at and near the end of their life for many nurses is part of basic nursing care. And we do say, and I use the phrase, that end of life care is everyone's business. As a specialist team, I work with a very skilled, very knowledgeable, very talented team of nurse specialists, of specialist support nurses, of consultants and registrars, of physiotherapists and occupational therapists, as well as psychologists. And we are here to be called upon for the situations and the challenges where things are tough and complex, or even if what to do isn't completely certain, and we can be here as a sounding board. But we are small teams, and within CUH, when we've audited and looked at the number of people who have died in the trust where we've been involved, we have only been involved in about 10 to 20% of cases. So that's a whole 80 to 90% of dying people who may not have needed us and whose needs, I hope, have been met perfectly adequately by their treating teams and by their ward teams.
Perfect. Thanks for that. We've got another question. Are you able to say a little about the differences between palliative care in hospital and hospice? What precipitates the decision to move to hospice?
So there will be a few reasons why we admit people to a hospice. The main differences between a palliative care in a hospice setting and palliative care in a hospice setting. One is about the environment. Hospices are generally quieter, more homely places with a much more therapeutic environment. Their staffing ratios are often more generous than ward nurse to patient staffing ratios, and they are also supported by an army of volunteers who will sometimes be able to come and stir the sugar in a patient's tea if that's what a patient needs. Hospice is also run on a huge amount of goodwill and charitable support. Hospitals are very different environments for those of us who work in hospitals. We are busy, we are pressured, it is noisy. A lot of our focus is on things that are sick. And despite the best efforts and the best care and attention of everyone, physically it is sometimes just not possible in a hospital setting to give that same quality of care that hospices can provide. There are other differences in that as well. In a hospice setting, people are admitted to hospice with very clear diagnoses and prognoses, whereas, as I said, in hospitals, often the prognosis, the potential for recovery is uncertain. So that is a challenge for everyone, for patients, for their families. Uncertainty is often harder than the knowledge of bad news and certainty that a prognosis is short. When I talk to my patients and their families, they will say the not knowing for sure, that is the hard thing. Also, I think that people who go to a hospice have consented to be there. People choose to go to a hospice. We do not refer people or transfer people to a hospice unless they've consented to it. And the reasons why we might send people to a hospice might be because we genuinely think that they're in the last days, the short weeks of life. It might be because they have complex symptom control needs, and our expectation is that those patients will have their symptom control improved and will then be discharged. There are some things that hospices can do in terms of medical care and treatment, but they're not mini hospitals, so we do have to be careful about what patients' medical needs are before we transfer. So there is a part that all treating teams and responsible clinicians need to play in agreeing that the patient would be safe to be managed in a hospice. But for me, the most important person and people in that decision making is the patient we're looking after, the person at the centre of this, and the family and the people around them. There is one other part to that I should say, though. There are some people who very reasonably do want to be in a hospice, but we might not refer for the reason that hospices can only function by being short stay units. So all of our local hospices can only continue to function and meet the needs of their patients by being ruthless and efficient with how they use their beds. And so the average length of time that someone can spend in a hospice is between 1 and 2 weeks. And for some people for whom they would love to go to a hospice, but we know that they're in the last months of life, and we know that their care needs are such that actually they're going to need the level of care that could only be met in a nursing home. For those people, sometimes moving them to a hospice for a couple of weeks and then moving them to a nursing home, it's just not fair. It's just not fair on them. Yeah. It's hugely frustrating for everyone. It's hugely disruptive. So actually for those people, sometimes part of our job is to have that difficult breaking bad news conversation that although the hospice is there, it might not be the best choice overall for that person thinking about what their life is going to look like for the weeks and months ahead.
Perfect. Thank you for that, Doctor. We've got a few questions coming in. We've got one from Sylvia Carter and asking, does the respect form come in at any time in Addenbrooke's?
So my view, both as a palliative medicine physician and a patient safety lead as well, is the respect form and the respect conversation should be integral to almost every patient's journey through the hospital, whether or not they have an acute illness, or whether they have a life-threatening illness, or whether they have a chronic or a life-limiting illness, because the whole point of a respect form is to make sure that whatever we do as clinicians to a patient is in keeping with their wishes. And I've said already that palliative care and active treatment are not mutually exclusive, and I've said once or twice that for some patients, having good palliative care alongside active treatment makes that active treatment more tolerable and therefore more likely to be successful. But I could turn it on its head. Best symptom control will come from treating the underlying cause, if at all possible. If someone has, for example, a painful bone lesion from their cancer, irradiating, giving radiotherapy to that lesion is a far more definitive treatment for that symptom than the medicines that we might give for symptom control. And for other patients with, say, non-malignant conditions, for example, chronic obstructive airways disease, for patients with heart failure, there is a rough rule of thumb when it comes to predicting prognoses that those are patients who will often do better than their clinicians think they do. And those are patients that I would encourage junior doctors and treating teams for those patients to actually, they are worth fighting for at 2 o'clock in the morning, even though they may be in the last months or year of life, because in that acute phase, in that acute illness, they might well prove everyone on, and very often those patients do. The important point then is to make sure that whatever it is we're doing is in line with what that person wants, because against that, some of our patients are just fed up of coming into hospital. They're fed up with blood gases. They're fed up with being put on tight-fitting masks or noisy breathing machines. And for us as clinicians, the important thing to do is to make sure whatever it is we're doing is in line with what that person wants, and being realistic and honest with what we think we can achieve. And that is at the heart of the respect conversation. So although respect does get talked about within end of life and palliative care circles, and it is a very important document, it is just as true for many other patients in a hospital.
Okay, thank you. We've got a few more questions here. It looks like we will be running a little bit just over the half-an-hour mark. We do apologize for that. Next question is, you've talked about the importance of communication with the patient and understanding and getting to know them. If a patient is unable to communicate well, how do you deal with this?
So my starting response to that question is it will always depend, because it will depend on what the communication impairment is. It will depend on the physical state that that patient is in. In general, it is always worth trying and getting to know that person either directly or indirectly through their families, through their loved ones, through people who know them best is incredibly helpful. For patients for whom language is a barrier, there is, although some families are very good, willing and willing to interpret, there is no replacement for an objective professional interpreter to help separate out those roles so that the family and the patient can be there in the conversation without trying to be in two different places. Mm-hmm. For people with sensory impairment, with hearing impairment, COVID has been a real challenge, wearing masks and so on, but Cambridge had some very good technological solutions to help us communicate with patients who had hearing impairment, where we might need to use picture charts, iPads, word charts to show them what we were saying. For some patients with cognitive impairments and impaired capacity, or dementia patients who can still communicate, but perhaps their communication is less verbal, it does come back to watching, engaging, seeing how they behave, and using those obvious human ways of communication like facial expression, like gesture, like touch, in order to try and build a relationship, in order to try to get a sense of where that person is. I suppose this is a kind of situation where I make reference to a German journalist called Kurt Tucholsky, who quoted during the Second World War that cruelty is a lack of imagination. And I can't give a straightforward answer to what my approach would be to someone who has difficulties in communicating, because that is such a broad area. But my take-home principle is, if you're thinking, if you're caring, and if you're engaging your imagination in trying to communicate, you won't go too far wrong. And at the end of the day, we're never on it alone, and there are always people to ask for help.
Thank you for that. I've got two more questions. We've got Sylvia Carter asking, when do you fit in after someone is told they're terminally ill, as it did not happen for them?
I'm very sorry to hear that. Although I should say as well that for a great many people, as I've said, they do not necessarily need us in palliative care at that moment. As we said already, people are individuals and everyone is different. Certainly everyone should have the opportunity to be offered a referral to a service like ours, whether that's a hospital team like ours or a community palliative care team. There are a lot of services that do similar roles to us. I think one of the things that I've recognised over the years is that the patients who get referred to us in palliative care, they're not referred because of the diagnosis of a terminal illness, for example, nor are they necessarily referred because of their physical symptom like pain. They're referred to us because of how they feel about it. They're referred to us because of how their families feel about it. And it is that level of distress, it is that emotional suffering that often is the difference between a patient or a family living with a life-limiting or terminal condition or a physical symptom like pain, but are okay and can be managed by their GPs, by their hospital teams, by their site-specific nurse specialists, for example, and by the panoply of other support services that are available for some people. And those people who really do need us, because it is that intensity of distress that turns something that would otherwise be manageable into something that is complex.
Perfect. Thank you for that. And finally, just to get to our last question, as for the pain management, what is the difference of your team with the pain team?
So in one sense, our roles overlap. We have a fantastically skilled pain team in this hospital. I think that for palliative care, there are possibly two ways in which our roles might be distinct. We historically have looked after cancer pain as a specialty for decades. We have a knowledge and understanding and experience of different kinds of cancer pain, bone pain, instant pain, neuropathic pain, breakthrough pain in the context of terminal illness, and utilizing drugs and medications, sometimes at doses that would make an average pain specialist or average physician's eyes water, that for us, we know is safe because we are the experts and we know what we're doing. So in one sense, there's a group of patients with pain that we have a greater body of knowledge and experience in managing. Pain teams equally have groups of patients with, say, a symptom like pain, that they have much greater knowledge and experience of, and the group of patients, I think in particular those patients with so-called chronic pain. And over the years, we have come to recognise as pain specialists that the approaches that we give for cancer pain are very different from the approaches that we need to give for patients with chronic pain. And where that has not been understood, in parts of the world like North America, where that has not been understood, that has led to enormous scandals and patient safety issues by patients who have been inappropriately prescribed strong opioids like oxycodone, and they have become dependent on those. And so there are patients who suffer with chronic pain, for example, where I personally have a concern that the risks of palliative care involvement for those people start to outweigh the benefits, and where pain services who are much more familiar and have a much more expert understanding of those patients' needs are much better placed in order to meet those people's needs. Within a hospital setting, there is a grey area. There is an overlap. And as with so much in life, we achieve our best results by talking together and working together.
And finally, we have comment from Frankie Williams, who's resonated well with one of your phrases. Thank you. I was interested in your phrase, the golden thread of continuity. This struck me as an all-important point, and a good practice might do well to adopt that approach when frail elderly are admitted to hospital with multiple problems, that would mean expanding a team?
I think that healthcare in the NHS has evolved over the decades. For those of us who've worked in the NHS and healthcare for more than 10 years, have lived through and seen a lot of changes organisationally, structurally, politically, not alongside the changes in the evolution in clinical roles and the increasing demands and the progressive diminution of resources. There are some things that we've gained that have been positive, and there have been a lot of things that we have lost, that we missed. And that continuity of care is something that, very sadly, I think in hospitals has become weakened and we have lost over the years. And that is not just a shame. That should worry all of us who work in healthcare. That should be on all of our minds, because it is those breaks in between the continuity that people are at most risk. It is those breaks in between that continuity where well-intentioned healthcare professionals repeat the mistakes that their predecessors have made because they weren't there. And although we pay a lot of attention and time to improve our handover processes, to improve documentation, to improve our records and to enhance that seamless care, humanly, there is no replacement to being there. And for some of our patients who are at near the end of their life within a hospital setting, if we can see that those are patients who are moving from ward to ward or team to team, because we recognise that people who are sick, who might get better, look very similar to those people who are dying, who are not going to get better. And if we are not there as that continuity to make sure that Team B receiving a patient from Team A knows that that is the situation, that message can sometimes fall into the cracks. And we only get one chance to get it right for those people, which is why being a safety net for that continuity for some people starts to become helpful. And for Michael, when he was referred to us, it was that vulnerability that jumped out to us. It was that need that we could see screaming, even though in the moment his palliative care needs were not so complicated. It was the situation that needed management.
Indeed. That brings us to the end of our Q&A. We do apologize for running over the allotted time. Thank you very much, Dr. Ben, and for the insightful talk on palliative care at CUH, and very interested to see how we were able to cover from the impact of COVID had on palliative care. This brings us to the conclusion for our webinar today. Thank you for joining us, and the recording for the webinar will be available on, and the link will be shared on the CUH bulletin and the August membership newsletter. Thank you very much. Bye.